Good evening, everyone. A warm welcome to the BMC Oncology webinar series, hosted by Balco Medical Center and supported by AstraZeneca, MCure, Intas, and OneCell. The theme for today's webinar is Changing Paradigms in GI, Ovary, Breast, and Lung Cancer Management. Today's webinar is chaired by Dr. Bhavna Sirohi, Senior Medical Oncologist and the Medical Director of Vedanta Medical Research Foundation, Dr. Gaurav Gupta, HOD and Senior Consultant of the Radiation Oncology Department at Balco Medical Center, Naya Raipur, and Dr. Nupur Priya, Consultant, Surgical Oncology at Balco Medical Center, Naya Raipur. Before we begin, a few housekeeping points. The entire session will be recorded. If our participants or our panelists have any questions, they can put it in the chat box. And we have a case discussion towards the end of the session, so please stay tuned for that. So let's begin with our scientific program. Our first talk is titled Transforming Patient Outcomes with Newer Innovative Therapies in 1L Advanced MHCC. Welcoming Dr. S.P. Srivastav, Medical Oncologist from Kokilaben Hospital, Indore, who will guide us on the following. Over to you, Dr. Srivastav.
So at the outset, I would like to thank the organizing committee of Bolco and specifically Bhavna Sirohi ma'am, Gaurav, who is my very good colleague, and Dr. Nupur. Just we have introduced ourselves to each other. So as we know, this and the disclaimer that these are the slides being provided from AstraZeneca for academic purpose only. So as we know, this unresectable hepatocellular carcinoma is a very big burden of disease in our country, and the biggest problem is the mortality of this disease. And there are lots of unmet needs in the management of this disease. So we are discussing in next 20 minutes for some of the newer modalities or therapies which are there in this management of this disease. So my presentation would be on transforming patient outcome with innovative therapies in advanced unresectable hepatocellular carcinoma. So here we see this is from the Globocon 2022 data, where we can see this liver cancer. Liver cancer is the 7th most common cancer and 4th most frequent cause of cancer-related death globally. If we see this pie chart here, we can clearly see this out of 86,000 new cases diagnosed yearly of liver cancer, and almost 75 to 76,000 patients died because of this disease. So it is having a high burden mortality globally as well as in our country as well. So the reason for that probably because this disease mostly most of the cases are being diagnosed in advanced stage. Almost 45% are cases being diagnosed in with the regional spread or with the distant spread of this disease. So either in the form of lymph node metastasis or metastasis to some other organ. And that's how the prognosis becomes poor. We see the 5-year relative survival by stage. Fortunately or coincidentally, when the patient are getting diagnosed in localized stage, there is a very good survival for 5 years, that is 30%. But where we see the distant part, it is merely some patients are getting survived. If we see the Indian data, it is again from the Globocon 2022 data. Here we can clearly see the similar scenario that the incidence is almost 38,000 cases every year and death is almost 37,000 cases are being died because of this disease. So hardly few patients are surviving with the disease. Here, this disease is very common in male as compared to female. There is a 4:1 ratios there, and being diagnosed in 40 to 70 year of age, and the frequency increases with the increasing age. The common association is cirrhosis. In India, it is 1.6% per patients getting diagnosed with cirrhosis every year. So if we see the number of patients diagnosed on the basis of BCLC staging, so most of the 50% patients are diagnosed in the BCLC AB stage, and in BCLC CD, it is 50% of patients. So it is quite a high number of patients are diagnosed with the advanced stage. The etiology or risk factor, if we see this etiology, chronic infection, that is viral infection, metabolic syndrome, sometimes this is a non-alcoholic steatotic hepatitis and chronic alcohol abuse, which leads to cellular stress and cell death, which cause deregulated liver immune network working in the form of immune suppression and exhaustion, and missing tumor surveillance and proliferation and pre-oncogenic transformation transition, which leads to fibrosis, which leads to cirrhosis, and then finally it converts to the hepatocellular carcinoma. So there are multiple mechanisms of immune escape or evasion, which includes overexpression of CTLA4 and PDL1 and inhibition of antigen presentation. So this is the similar slide as before, that there are the various causes, but here we'll focus on the metabolic causes. So NAFLD, non-alcoholic fatty liver disease, NASH, and obesity and diabetes. These are the risk factors which directly can cause hepatocellular carcinoma without being going through the cirrhotic phase of the liver. But rest of the etiologic factors, they go with the chronic inflammation, cirrhosis, and lead to hepatocellular carcinoma. So that is a very important aspect to discuss. And there was a study which was where they have tried to rule out what would be the most common etiologic factor. So in that, the most common etiology of hepatocellular carcinoma was NAFLD. Almost 36% patient would diagnosed with because developed SCC because of NAFLD, followed by a viral hepatitis B and C infection and harmful level of the alcohol abuse. So NAFLD is very important risk factor. Then management. Now we will discuss the management of advanced unresectable hepatocellular carcinoma. So this is the BCLC staging, and on the basis of that, we usually decide the treatment in our clinical practice. So we'll discuss here for the advanced stage disease, that is the C, BCLC-C, portal invasion and extrahepatic spread is there, and preserved liver function with good performance status. The systemic treatment, which includes in the first line atezolizumab or durvalumab, and if not feasible, then TKIs like Sora, lenvatinib, or durvalumab single agent can be tried. In second line, Rigora, cabozantinib, ramucirumab is there, and in third line, cabozantinib, that is the option. So if we see the evolution of systemic treatment in advanced and unresectable hepatocellular carcinoma, so in 2007, we got sorafenib for the first line. And after a long gap of 10 years, we got the another drug, that is the regorafenib, but that was in the second line. And next year, 2018, we got another drug, lenvatinib, in the first line for the SCC. And then every year we get something like 19 cabo and rami. In 2020, atezolizumab in the form of immunotherapy and the VEGF inhibitor. And in 2022, we got two dual IO, Tremali and Druva, as a first line management of hepatocellular carcinoma. So on the basis of the baseline studies, SHARP and REFLECT, if we compare these studies where the SHARP compare the SORA plus placebo, but LENVA compare sorafenib and REFLECT study. So what we have seen this efficacy specifically, we see the sorafenib got the median overall survival of hardly 10.7 months. When we go in the REFLECT study, the LENVA slightly improved the median overall survival, but that was not quite high. And so there was a modest improvement in OS and the considerable side effect associated with both treatment underscore the unmet need for better clinical outcome in management of hepatocellular carcinoma. That's how the immune checkpoint inhibitor and anti-VEGF came into the role. And that was based on the IM Brave 150. That was a phase 3 study which evaluated atezo plus Web versus sorafenib in first line advanced unresectable hepatocellular carcinoma, where they have taken the locally advanced metastatic unresectable SCC patient in the first line setting. Various regions were taken in stratification group, and a good performance patient was taken. They have stratified on the basis of macrovascular invasion, extrahepatic spread, and baseline alpha fetoprotein less than 400 and more than 400 as well. So 2:1 randomization was done. Atezo 1200 milligram 3 weekly, bevacizumab 15 milligram per kg 3 weekly, and compared with the sorafenib 400 milligram BID. So almost 500 patients they have taken, and treatment was continued until the loss of clinical benefit or unacceptable toxicity. The co-primary endpoint was OS and PFS. And if we see the graphs of OS and PFS in atezolizumab arm has clearly shown a benefit as compared to the sorafenib. We see this Data-wise, median OS was almost 6 months higher in atezolizumab as compared to the sorafenib, and median PFS almost 2 months higher in atezolizumab as compared to the sorafenib. So clear-cut benefit was atezolizumab was there. And if we do the subgroup analysis, so except non-viral hepatocellular carcinoma, in all other subgroups, atezolizumab shows a better response as compared to the sorafenib. If we see the safety aspect of this, so when we are comparing atezolizumab, so mainly the side effects were because of the bevacizumab, that is hypertension and proteinuria, that is usually we have seen in our clinical practice. In SORA, if we compare the diarrhea, the hand-foot syndrome, appetite decrease, and hypertension, these are quite high as compared to the atezolizumab arm. So later on, the dual IO came into the picture, and the rationale for that dual IO was that they have combined two kind of different mechanism: anti-CTLA-4 inhibitor and anti-PD-L1 inhibitor. So anti-CTLA-4 inhibitor acts lymphoid compartment to increase the number of T-reactive cells, as the anti-PD-1 act in tumor microenvironment to prevent the T cell inhibition, and both combiningly enhance synergistic anti-tumor activity. So as we have seen that there are the two different kind of mechanisms: CTLA-4 inhibitor, that is tremelimumab, which regulator of T cell activation in lymph node following antigen presentation, and PD-L1 inhibitor durvalumab, which cause the adaptive resistant induced T cell exhaustion in tumors. So already we have an idea about that dual IO works in melanoma, but the toxicity was there because of the continuation of dual IO, particularly CTLA-4 inhibitor. So what they have tried to see that could a single priming dose of tremali, that is CTLA-4 inhibitor, with durvalumab improve immune-mediated clinical activity in hepatocellular carcinoma patient while minimizing toxicity, because continuation of CTLA-4 inhibitor led to a significant toxicity to stopping the treatment in the further cycles. So on the basis of that, phase 2 study 22 was done, where they have studied 22 trials, where they have evaluated tremali durva in unresectable hepatocellular carcinoma, including the steroid regimen, which is a main standard treatment as of today. So they have done in the various part. In the first part, they have run the safety for tremali 75 plus durva. In part 2, they have randomized in three different arms: tremali 75, then durva and durva alone, and tremali 75. And here they have run the safety for the tremali 300 plus durva. Part 3, they have compared all the four arms, and what they have found that stride, that is a tremali 300 plus durvalumab arm, which has shown the longest median overall survival in study 22, and median OS in stride arm was more than 3.6 months longer than all other treatment arms. In addition, one event was observed at 27 months in stride arm, and stride regimen demonstrated acceptable safety profile, and no new safety signal were observed. So that's how the base was planned, and for the single dose of CTLA-4 inhibitor. So on the basis of this study 22, the phase 3 randomized study, that was open label multi-center study of tremelimumab plus durvalumab as first line therapy in patient with unresectable hepatocellular carcinoma was done. That was known as Himalaya study, where they have inclusion criteria is unresectable hepatocellular carcinoma of more than 18 year of age, with BCLC stage B or C patients were taken. In the first line, child A were patient were taken, and good performance stages were patient were taken. So randomization was done in 1:1 arm. In the four arms were there. So arm A was durvalumab 1500 milligram 4 weekly and tremelimumab 300 milligram single dose only. Arm B was durvalumab 1500 milligram 4 weekly. Arm C sorafenib 400 milligram BID, and Arm D they have not evaluated durvalumab 15 and durvalumab 75 milligram 4 doses. So only three arms were compared, and their primary endpoint was overall survival. So this is the schema of various regimens. So we see the durvalumab 1500 milligram 4 weekly and tremelimumab, and in the stride arm, that is the tremelimumab 300 milligram single dose, and further 1500 milligram of durvalumab 4 weekly. So in the demographic and baseline characteristic, almost similar in all four arms. And apart from after that, subsequent second line of anti-cancer therapies. So if we see the any therapy in the all three different the various arms, almost similar number of patients gone for the different treatment like targeted or anti-angiogenic or second immunotherapy and cytotoxic chemotherapy. So it was almost comparable. So here we see the OS data of the stride arm. Here we can clearly see that almost 22% lesser death risk compared to patient who has received sorafenib. So clear winner over here is the tremelimumab plus durvalumab with a significant HR value of 0.78. If we assess the subgroup analysis, here we can see this hepatitis C induced hepatocellular carcinoma slightly favoring, responded better with the sorafenib, but rest of the other subgroups, including male, female, age, region-wise, BCLC staging on the microvascular invasion or extrahepatic spread or AFP level, all were responded better in tremali plus durvalumab stride arm. If we see the tumor responses in the form of ORR and DOR, which was higher for steroid compared to the sorafenib and significantly higher. And if we see the side effect profile of this both the arms, so it is again we see the any treatment related events in the steroid arm is 75 versus 84%. Any grade 3-4 treatment related events, it is 26 versus 36.9 in sorafenib. So it is safer regimen to be used. Immune related, definitely it is higher in stride arm as compared to the sorafenib. So most common treatment related adverse event in stride arm were rash, pruritus and diarrhea. Diarrhea is significantly higher. That is the main complication what I have also feel in our my patients. That's difficult to manage sometime. And if we see the treatment related hepatic or hemorrhagic events, so here we can see this the patient with hemorrhagic treatment related events in stride, it is hardly 1.8% as compared to the sorafenib, where it is higher. And if it is grade 3, it is again in the higher in the sorafenib. And there was no hemorrhages, varices hemorrhages was there in both the studies with the arms. So on the basis of Himalaya study, this hepatocellular, this NCCN 2024 version, which has given this as a category 1 recommendation for tremelimumab and durvalumab for unresectable hepatocellular carcinoma, along with atezo and web. So conclusion of this study that hepatocellular carcinoma is one of the topmost common cancer affecting Indians. There is a shift from viral to non-viral etiology. NFLD responsible for more hepatocellular carcinoma in current era as compared to the viral etiology. Immunotherapy combination have shown better anti-tumor activity than TKIs alone. Atezolizumab has shown a new standard of choice in advanced hepatocellular carcinoma. The stride regimen where the single tremelimumab 300 milligram and durvalumab 1200 milligram 4 weekly improve overall survival as compared to the sorafenib and demonstrated an unprecedented 3-year overall survival rate. The stride seems to benefit across all subgroups, including the non-viral etiology patient population, and the stride was well tolerated with low rate of discontinuation in gastrointestinal hemorrhage. Stride and durvalumab monotherapy represent potential new treatment option for patient with unresectable hepatocellular carcinoma. And in the end, I just like to share my experience. I have used this stride regimen in 2 or 3 of my patients. I have seen a early responses and patients' general condition improve quite faster as compared to the atezolizumab. So with this, I just like to thank the organizers. Thank you so much.
Thank you, Dr. Srivastava, for a very enlightening presentation.
Sir, hi sir. Sir, I am Dr. Yashwant, medical onco. Sir, I
Hi.
have one question that
Yes.
a patient with active hepatitis C infection, should we
Yes.
start antiviral and wait for giving stride regime or we can go directly?
We can go directly along with the antiviral therapy. There is no unless there is a very high viral load, we should not wait for the treatment. If it is a very higher load, then should start antiviral therapy for almost a 2 week, then again recheck the viral load, and then we can start. Otherwise, most of the patient we don't require to delay the treatment with immunotherapy.
Okay. Thank you, sir.
Thank you.
Thank you, sir. Our next speaker is Dr. Rajiv Ratan Jain, Professor Radiation Oncologist at Regional Cancer Center, Raipur. Dr. Jain will take us through the evolving landscape in the hormonal management of prostate cancer. Over to you, sir.
Hello everyone. I'll be speaking on evolving landscape in hormonal management of prostate cancer. Yeah. So starting with what is the prostate cancer epidemiology. Next page, please. Prostate cancer is the fourth most common cancer globally by incidence rate, and mortality wise, it is eighth most common cancer. And next slide. But if we see Indian data, so in Indian data, prostate is 12th among the top 12 top cancers in our patients, and mortality-wise, it is 14th in number. So we also are having a surge in number of prostate cancer as the number of patients surviving and as the population is surviving more, the number of people getting prostate cancer is also increasing. Next slide. So if we see what is the hormonal management for prostate cancer, so there is LHRH agonist and antagonist, and they two work differently, but the final outcome is same. LHRH agonists are synthetic protein which are structurally similar to LHRH, and they bind to LHRH receptor in pituitary gland, and pituitary gland then stops producing luteinizing hormone, and testicles are not stimulated to produce androgen. Four types of LHRH agonists are leuprolide, gosarline, triptorelin, and hysterelin. LHRH antagonists, while they bind to LHRH receptors in pituitary, and they directly stops producing luteinizing hormone, and testicles are not stimulated to produce androgen in this setting. The only one example to antagonist are Dagarelix. So how does hormone therapy acts? So Gosarline, if you see Gosarline is available uh, in two combinations. One is 3.6 mg and second is 10.8 mg implant. That is depot formulation. That is a pre-filled syringe for subcut injection with a 16 gauge needle, 3.6 mg, 1 monthly dosage, and 14 gauge 10.8 3 monthly formulation. So the installation of the drug is very easy. It is single step delivery system and minimal administration time are additional advantage. The implant help in gradually releasing of medicine over intended period and is administered by a safe system syringe with a protective needle sleeve to prevent needle stick injury. Moreover, Gosarline is not a liquid injection, so there is no need to displace the air bubbles. While if you see Degarelix, next page please. Degarelix as a monthly depot formulation, Degarelix actually require reconstitution, and it is administered deep subcut every 28 days. So we need an initial dose of 240 mg, two injections of 120 mg at concentration of 40 mg per ml, and a maintenance dose of around 80 mg. So the main drawbacks are more frequent dose administration if we compare to Gosarline or agonist, and there is actually no long-acting depot available. Longer time of required for injection reconstitution, and inconvenience of two injection during treatment initiation. This is the third drawback. Next slide. If we see the plasma protein binding of all the three drugs, we see that Degarelix have a 90% plasma protein binding. If we see all the other two drugs, Gosarline, the two different formulations, so there is no need for adjustment for mild to moderate hepatic impairment with Gosarline, unlike Degarelix. Degarelix we require a if we have mild to moderate hepatic impairment, we will require a dose correction. Next. And if we see cardiovascular data, so earlier it was thought that the degarelix is better in cardiovascular patient. But if we see data, prostate cancer, prostate cancer is a disease of old age and advanced age itself, and will have multiple, patient will have multiple comorbidities like hypertension, hypertriglyceridemia, insulin resistance are very prone to adults. So it is more likely that patient of prostate cancer will have one or more comorbidities at the beginning. It is very common. So patient with a recent cardiac history, cardiovascular disease history appears to have a higher risk, and increased physical activity may decrease the symptoms. So if we next page. So if we see the evidence that suggests that both goserelin and degarelix have a similar acute and long-term safety profile, most common adverse events are like hot flushes and weight increases associated with goserelin are caused by a decrease in testosterone level, while injection site reactions forms a most common adverse event of degarelix. Next slide. So there was like 2-3 trials I'll discuss about cardiovascular risk. There is a pronounced trial in pre-existing CVD patients. It was a randomized trial and next page. So if we see this trial, the relative cardiovascular safety of GnRH antagonist was compared with agonist in men with prostate cancer who had known atherosclerotic cardiovascular disease. It was an international multicentric prospective randomized and open label trial. Men were randomly assigned 1:1 to receive GnRH agonist and antagonist for 12 months. Primary outcome was time adjusted major adverse cardiovascular event and composite of death, myocardial infarction, or stroke through this 12 months. Next slide. So what was the result in all this patient? 545 patients from 113 sites and 12 countries. The median age was 73 years. 49.8 had localized prostate cancer, and 26.3 had locally advanced prostate cancer, and 20.4 had a metastatic disease. If we see cardiac events, 15 like 5.5% of the patient assigned to antagonist and 4.1% of patient assigned to agonist had a cardiovascular event. So it was similar in both groups. So there was no difference in major adverse cardiovascular event at 1 year between patient assigned to GnRH antagonist or agonist. This was observed. Next slide. There is another study which was a real world evidence risk of cardiovascular disease followed by gonadotropin GnRH agonist and antagonist in prostate cancer, and it actually had they used 5 databases, and Grigor was a writer for this study. Next page. So the aim of study was to compare the risk of CVD patient with GnRH agonist and antagonist in real world setting of UK, Scotland, and European countries. It was first observational study to directly compare the risk of CVD outcomes between agonist and antagonist by using country specific analysis for patient level data in 5 countries. 6 CVD outcomes were explored: any CVD, ischemic heart disease, acute MI, arrhythmia, heart failure, and stroke. Total median follow-up time for United Kingdom, Scotland, and Belgium, Netherlands, and France was 1.8 years for GnRH agonist and 1.2 years for GnRH antagonist. Total mean age for 5 countries was 74, and for GnRH agonist was 73. So it was equal. Next page. So a total for 48,757 men were on GnRH agonist and 2,144 on GnRH antagonist. There was no difference in CVD for any risk for any CVD for men was with agonist and antagonist. The no difference, and men on GnRH antagonist showed increased risk of acute MI. And arrhythmia. Like if we see the HR ratio, hazard ratio, 1.62 in antagonist and 1.55 in with arrhythmia, and compared to GnRH agonist. So men with prostate cancer given GnRH antagonist with a history of CVD event indication had a 30% higher chance of developing any CVD and 63% higher chance of developing acute MI and 74% higher chance of developing arrhythmia compared to men on GnRH agonist. There was no statistical difference in risk for any CVD for men on GnRH agonist and antagonist. Next page. There was a nationwide population-based cohort study with androgen deprivation therapy of cardiovascular risk, and no meaningful difference between GnRH antagonist and agonist in a nationwide population-based cohort study was seen in a French Heart Institute heart insurance data. Next. So the design was study was an observational retrospective cohort study in prostate cancer who initiated ADT, androgen deprivation, with gonadotropin releasing hormone or agonist or antagonist, with an anti-androgen combination, combined androgen blockage, or had an orchidectomy between 1st July 2010 to 31st December 2011, followed them up to 31st December 2013. 5 type of CVD events were seen: incident of fatal, like ischemic heart disease, acute MI, cerebrovascular stroke, chronic heart failure, arrhythmia, and aggravated outcome was defined as the occurrence of any of these 5 types of CVD followed during follow-up. So result, if we see results, 71% received GnRH agonist and 12% had CAB, 13% have arrhythmia, 3.6% had with the GnRH antagonist, and 0.6% has an OT. So no meaningful difference between agonist and antagonist was seen. So if we see all those 3 studies, one with the nationwide cohort study and a comparative study as well, there is no difference between GnRH antagonist and agonist in terms of cardiovascular risk. Next slide. So there is another thing which I want to discuss is shifting from GnRH antagonist to agonist. Next slide. So there was a study which was published, change from gonadotropin releasing antagonist to GnRH agonist therapy that does not affect the oncological outcome in hormonal sensitive prostate cancer. So what they did, they started the patient on antagonist, and once the patient was on controlled disease wise, like PSA wise or PSA wise, or if metastatic disease was controlled, so they shifted it to GnRH agonist therapy, and they saw that the shifting patient from antagonist to agonist was associated with improved 5-year survival. Next page. So if the retrospective study, 108 patients with prostate cancer who were treated with antagonist, treatment was changed from antagonist to agonist in 57 patients, and in 51 patients, treatment with antagonist was continued. Next page. After completion of 5 years, what they saw that switched from antagonist to agonist group had a 96.6% of OS compared to the only antagonist group which were continued till antagonist. They had 74.1% of OS, and 5-year cancer specific survival was up to 100% in the switched over group as compared to 84.6% in antagonist group, and average time to castration resistant prostate cancer 43.3 months versus 35.2 months. And this was statistically significant data. Next slide. So, to evaluate the effect of changing treatment from Dagger-Helix to GnRH agonist for after achieving a stable disease control on clinical and oncological outcome, lower serum level of PSA and alkaline phosphatase were maintained after changing the therapy from antagonist to GnRH agonist. The switch to GnRH agonist did not affect the serum testosterone level. They were maintained below the castration level. In the changed group, conclusion is that switching from antagonist to GnRH agonist is an effective treatment of prostate cancer. Next slide. So time to castration resistant, if we see if we see only Dagger-Helix, so there is clear-cut benefit in patient who were taken on Dagger-Helix and then GnRH agonist, then converted to GnRH agonist once it was controlled. Next slide. So another oral GnRH, which relugolix, 5 reasons why US Food and Drug Administrator should have exercised restraint. This is another drug which I want to talk. The reason for restraint. Next slide. First, the quality of control arm was suboptimal. The study randomized patient in 2:1 fashion to receive either oral antagonist or injectable LHRH agonist every 3 months. The perceived benefit, actually what they saw, the primary endpoint was not patient oriented. It was not like PSA control or patient disease control or overall survival or even preventing metastasis. The primary endpoint was testosterone level, which was testosterone level. In the context of trial, the incidence of diarrhea was nearly doubled in oral antagonist group comparing to agonist group, 12.2% versus 6.8%. And there was no evidence of improvement in quality of life presented. Next slide. Fourth, the exclusion criteria may create a selection bias. Patients were excluded for trial if they were expected to undergo chemotherapy or surgical therapy within 2 months of initiating ADT. So, nowadays we follow STAMPED guidelines, which says that all those patients with high disease, high volume disease, we should start with with chemotherapy and ADT together. For patients with metastatic disease, combination therapy is becoming the new standard of care. If research claims that a pill of androgen deprivation is integral, then oral must be tested in the light of prevailing standard of care. So this oral drug should have been compared with chemotherapy and androgen deprivation therapy. The present trial is insufficient for firm conclusions, and new randomized trial for patient-oriented endpoint measure what is relevant to patient, example survival, quality of life, and metastasis are required to determine whether oral antagonists help patient in living longer or with a better quality of life. Next slide. Additional criticism of study includes only a small subset of patients receiving concomitant therapies with anti-androgen agents such as enzalutamide or anti-cancer agents such as docetaxel to assess the safety of oral antagonists, which may often be used in combination with this agent in real-world practice. Next slide. NCCN says that oral antagonist has not been adequately studied in combination with potent androgen receptor inhibitors such as enzalutamide, apalutamide, or abiraterone, nor it has been studied in combination with docetaxel or cabazitaxel. Further studies of dosing and drug interaction with commonly used agent in advanced prostate cancer are needed to ensure patient safety and proper dosing. And data are limited on long-term compliance of oral antagonist and potential effect of optimal ADT. Ongoing monitoring of sustained suppression of testosterone can be considered, and oral may not be preferred agent if patient compliance is uncertain. Next slide. Next slide. So, other advantage of GnRH agonist over antagonist is GnRH agonists provide more consistent and sustained suppression of gonadotropins. This is particularly beneficial in long-term treatment with stable hormonal suppression. Oral antagonist issues of compliance and like toxicities, so are likely need for continual testosterone monitoring are possibly barriers that are not routinely of concerns for patient receiving injection therapy. Although GnRH antagonists do not produce flare, they do have to be given at a higher doses than GnRH agonists, and there is a potential for theoretically greater risk of side effects. Next slide. So Goserelin has clinical data across three key prostate cancer settings. First is localized cancer, a 40% improvement in 10-year overall survival versus RT alone with adjuvant Goserelin or neoadjuvant or adjuvant Goserelin. There is two studies to support it. In locally advanced prostate cancer, a 46% reduction in risk of progression over 10 years when added with RT or versus RT alone. In neoadjuvant setting like Goserelin RTOG 8610, TROC second is also I think RTOG 9601, and in Goserelin post RP is GETUG AFU 16 trial. In metastatic setting, we all know that as effective as surgical castration in clinical outcomes. Goserelin versus orchidectomy, there are two papers to support it. Next page. EORTC 22863, Goserelin adjuvant therapy in high-risk localized or adjuvant prostate cancers. We regularly use it like newly diagnosed prostate cancer with T1 to T2 WHO histological grade of 3 or T3 or T4 or any WHO histological grade. No evidence of distant metastasis, and 1:1 randomization was done. Radiotherapy with Goserelin 36 months or radiotherapy alone, and hormonal therapy at progression. So actually 71% received the LHRH agonist and 24% received other treatment. Phase 3 open labeled randomized trial. Primary endpoint was clinical DFS. Secondary endpoint was OS, distant metastasis, free survival, cause specific mortality, and local regional control. So primary analysis conducted at median duration of follow-up of 45 months. Long-term analysis was with median follow-up of 9.1 years. Next slide. If we see like disease-free survival, 47.7% had a DFS rate when we give Goserelin with radiotherapy. When you compare it with radiotherapy alone, that is 22.7%, and 10-year prostate cancer mortality was 10.3% with Goserelin with radiotherapy, and only radiotherapy alone, it was 30.4 months with radiotherapy alone. So there was a definite benefit of adding ADT in patient with locally advanced prostate cancer, high risk category. Next slide. And there was 40% improvement in long-term in 10-year overall survival with Goserelin adjuvant therapy and RT versus RT alone. 58.1% versus 39.8%. 40% reduction in risk of death with adjuvant Goserelin. Next slide. So Goserelin has clinical data across three cancer settings: localized prostate cancer, locally advanced prostate cancer, and metastatic prostate cancer. And there is significant 46% of reduction in risk of progression over 10 years when added to RT versus RT alone. Next slide. Another study with neoadjuvant Goserelin plus flutamide and RT significantly improved disease-specific mortality versus RT alone in 10 years. Next slide. Survival results with neoadjuvant Goserelin plus flutamide and with RT and RT alone. If we see the 10-year data, the estimated overall survival were 42.6% in ADT plus RT arm versus 33.8% in RT arm, RT alone arm. in long-term follow-up of like 11 years, there was a trend towards improved OS with ADT plus RT through the fail to reach statistical significance. And all-cause mortality, if you see all-cause mortality was significantly improved in patient receiving 6 months of neoadjuvant gossaline plus flutamide and RT alone versus RT alone. 10-year all-cause mortality, 0-month arm RT alone 42.5 months versus 3-month arm of 36.7 in the combination group and 6-month arm of 29.2% in 6-month group. Next study, adjuvant gossaline following radical prostatectomy for prostate cancer. So rising PSA 6 months or later following radical prostatectomy, there was study which compared radiotherapy alone versus radiotherapy with gossaline. It was a phase 3 open multi-level multicentric randomized controlled trial, and primary endpoint was progression-free survival and secondary endpoint was OS and metastatic-free survival. And long-term analysis was with a median follow-up of 112 months. Primary analysis was conducted at median duration of follow-up of 63 months. Next slide. There was a 46% reduction in risk of progression over 10 years with gossaline in added with radiotherapy even in post-radical prostatectomy versus RT alone. So next is metastatic prostate cancer. It is as effective as surgical castration. So there are 2 studies. Next slide. 2 studies. One is Kesari et al. And another is Vogel Zhang et al. These 2 study had 292 patients. And when we see they both were randomized phase 3 trials. And what they told us that gossaline was equally effective as compared to surgical castration in both the arms. So we can use it in place of surgical castration. Next slide. So long-term outcome and overall survival, gossaline has an effective use for more than 3 decades along or in combination with other therapies in patients with localized advanced and metastatic prostate cancer. Gossaline has a well-established safety and profile with decades of clinical use, tolerability and patient compliance. Gossaline is generally well tolerated and fewer reports of discontinuation due to adverse event. Established protocol and clinical guidelines. Gossaline is included in numerous clinical guidelines and protocols for prostate cancer management and reflecting to trusted status in medical practice. The conclusions is, while data highlights the role of oral GnRH antagonist, it has several drawbacks like lacking survival data or clinical progression-free survival data. Gossaline has strong evidence and a time-tested drug in terms of extensive 10-year efficacy and tolerability data from randomized clinical trial in prostate cancer. Gossaline has data for randomized clinical trials to support all stages in prostate cancer, and large prospective comparative trials with long-term follow-ups are needed for oral GnRH. If we are trying to use oral GnRH antagonist, so we need a long-term data to support. Thank you very much. Thank you very much.
Thank you, Dr. Jain, for a very detailed presentation. Our next speaker is Dr. Sandeep Ojha. Dr. Ojha will be speaking on the role of NGS testing in breast cancer. Over to you, sir.
Good evening, everyone. So I will share my screen. Okay. So good evening, everyone. I am Dr. Sandeep Ojha, consultant and head laboratory services. Today, I will be discussing the evolving role of next generation sequencing in management of breast cancer. So let's start by the global scenario. As we all know, breast cancer is the most common cancer in women globally and is also the leading cause of cancer-related deaths. Approximately 2.3 million new cases diagnosed worldwide as per Globocan 2020 data. Most concerning is the increasing rates in younger women. and the cause are multifactorial, ranging from genetics, hormone influence, lifestyle changes, and environmental modifications. It's important to know that breast cancer is a heterogeneous disease with variable histology and variable molecular profiles, and difference in behavior and response to therapy for each patient. So, accurate tumor classification is very critical for a patient care along with personalized approach. What is the current approach in management? It starts with clinical examination and imaging like mammography, ultrasound, and MRI, which detects a lesion in the breast. Biopsy is performed for histopathology, and using H&E staining, we diagnose the cancer and we type and grade that tumor, whether it is ductal, no special type, or any special type of cancers like lobular, medullary, mucinous, etc. We also perform immunohistochemistry for hormonal receptors ER and PR and HER2, along with proliferation marker Ki67. And based on this immunohistochemistry, we further subclassify breast cancer into four subtypes: luminal A, luminal B, HER2 enriched, and basal. Like luminal A is ER and PR positive, HER2 negative, along with a low proliferation rate. Luminal B is also ER/PR positive, but with high proliferation rate and HER2 negative. One more subcategory of luminal B is there. It is HER2 positive. In this, ER will be positive, HER2 will be positive, irrespective of PR and Ki67. HER2 enriched, as the name implies, it will be ER and PR negative and HER2 positive, and basal is triple negative. So based on this classification and disease stage, the therapeutic strategies are made, and it involves multimodality treatment including surgery, radiation, and chemotherapy. Hormone therapy is given to patients who are hormone receptor positive, and target therapy against HER2 is available, trastuzumab, which are given to patients who are HER2 positive on IHC or FISH. But there are limitations in this conventional approaches because they often miss the subtle molecular changes in the tumor genetics. So it is molecular heterogeneity. The conventional approaches like IHC cannot identify heterogeneity or molecular heterogeneity. A tumor may show one molecular mutations in one area, while other area may show different molecular makeup. So it will lead to therapy resistance and ineffective treatment. So this conventional approaches also limit the prediction of outcomes and prognosis. So here comes the role of further tests like molecular markers, which can be performed using conventional PCR or next generation sequencing. Now coming to just overview of what is conventional PCR, here we amplify specific DNA fragment which are known to us. So we know that we want to check this mutation is present or not. So we will perform the conventional PCR. Okay, so it will be faster and will be of low cost. But what are the advantages of next generation sequencing? It is a high throughput sequencing technology, and it analyzes all the genomic alteration of the tumor simultaneously to identify actionable mutation for which targeted therapies are present. So it is very important that in conventional PCR we focus on single mutation which we think this can be present, but in next generation sequencing we can identify multiple mutations. Also, it has the potential to detect all the four classes of genetic variation like single nucleotide variants, insertions, deletions, copy number variants, and structural variants like rearrangement and translocation. So, as I have mentioned, that conventional PCR is faster and low cost. But if we compare to the number of genes sequenced, the here we identify multiple genes, multiple targetable genes can be identified. So it will be much cheaper than conventional PCR. So now coming to role of NGS in breast cancer. So it may be diagnostic, therapeutic, prognostic, and it also helps in making a relationship between primary breast cancer and recurrent breast cancer. How they are related and what changes have been occurred in the molecular makeup. So now coming to diagnostic utility of NGS. Many times diagnostic workup, it can be used for diagnostic workup of axillary lymph node metastasis of carcinomas of unknown origin, It can be used in differentiating metaplastic carcinomas with malignant phyllodes tumor and spindle cell carcinoma, which are one of the most common DDs for spindle cell neoplasm of breast. In metaplastic carcinoma, P53 mutation and EGFR amplification can be seen, while in malignant phyllodes tumor, TERT mutation and MET12 mutation can be identified, thus differentiating from each other. Also very important thing, as in cases with high risk individuals, early detection of the tumor, especially in case of familial breast cancer, we can detect this mutation before the tumor can be seen on imaging. So it is very important in early detection of in high risk cases. Also, it can detect rare variants, and it can be integrated with circulating tumor DNA profiling for non-invasive diagnostics. So, without any biopsy or FNAC, we can see circulating tumor DNA on peripheral blood sample also. Now, coming to therapeutic role of NGS, there are many FDA-approved therapies. This is image from the NCCN guidelines, which are many mutations like PIK3CA, which can be seen in HR hormone receptor positive cases, and where the hormone receptor therapies against estrogen are not working. We can identify these mutations by using NGS or PCR, and targeted therapy like alpelisib is available for this. Also, with NGS, we can see the germline sequencing, BRCA1 and BRCA2 mutation, for which PARP inhibitors are available. NTRK fusion can also be detected. Also, important thing, in many cases, some patients respond to estrogen therapy, and some may show resistance, or some may relapse. So this may be because of presence of ESR1 mutation, which is associated with resistance to aromatase inhibitor. So this mutation can also be detected using next generation sequencing, and targeted therapies are also available against this. NGS also can stratify the patients for immunotherapy by calculating the tumor mutation burden, and also looking for microsatellite instability. So MSI high tumor, MMR resistant tumor, deficient tumor, and high tumor mutation burden cases, more than 10 mutation per megabase, can be given pembrolizumab. Now, coming to prognostic role of NGS, high TMB indicate poor prognosis, but but also better response to immunotherapy. So, in patients with high tumor mutation burden, it may be worse prognosis, but the patient may respond better to immunotherapy. Also, NGS can track clonal evaluation, and can give tumor progression risk. It is also important in minimal residual disease monitoring. Patients who have taken the treatment and are on follow-up, and circulating tumor DNA can be detected using NGS for early detection of relapse. So it can detect the relapse on next generation sequencing. No technology is without challenges. So one of the important challenges, high cost and limited access. But as now increasing air connectivity to various major cities, and many labs doing this next generation sequencing, we are lucky to be have access to this type of advanced test. Another important challenge is the data overload. What happens? The NGS creates massive amount of data, so it generally can be difficult and confusing to interpret this. So specialized interpretation is required to interpret the NGS data. So interpretation complexity is one of the challenge, and also in germline testing, ethical issues to be considered, and patient consent and data sharing should be done carefully. So these are the challenges. And to wrap up, NGS is transforming how we approach the breast cancer, and it is revolutionizing breast cancer through precise diagnosis and personalized therapy. And it also promises a new era in precision oncology. As the access improves and technology evolves, NGS may become a cornerstone of breast cancer management. So these are the references. So thank you.
Sir, I want to ask something. Suppose if there is disease progression on chemotherapy, And
Okay.
so there is, should NGS be offered to the patient? And secondly, what is
Yes,
the
yes.
cost and downtime of the results? How much time does it take for the results to come?
Yes, definitely we can offer this NGS to the patient, and cost will be based on the number of which type of panel you want, and also duration. TAT is around 15 days from for many labs. It will take 10 to 15 days for diagnosis or for results.
Okay, sir. So are we frequently offering NGS, all the medical oncologists on the profile, on the panel?
Uh,
How frequently you are offering?
no, Dr. Yashwant can answer this.
Yes. Uh, for hormone positive, like Sir showed, for TNBC and hormone positive, we are offering NGS. For HER2, role of NGS is still evolving, but for other two, we are offering in metastatic setting.
Okay, sir. Thank you.
Thank you so much, Dr. Ocha. Thank you, Dr. Nupur, Dr. Yashwant. Up next is a much anticipated update, welcoming Dr. Deva Dulal Biswal, Senior Medical Oncologist at Balco Medical Center, Naya Raipur. Dr. Dulal will share the 10-year follow-up results from the Olympia trial. Over to you, sir.
Thank you, Achal. Good evening, all. So this is regarding olaparib. So we all know that olaparib works wonderfully in ovarian cancer, but this is a trial regarding breast cancer, and it's adjuvant treatment in breast cancer, especially if it is BRCA gene mutated. So Olympia 10-year update. This update actually came last year, and actually I during this preparation I learned, and I am convinced that this should be used. So PARP these are the backgrounds. PARP inhibition leads to synthetic lethality in cells containing BRCA1 or 2 mutation by impairing homologous recombination. This means, this complicated sentence means that the cancer cells, if they have BRCA mutation, then their DNA repair mechanism is partially damaged. And if we use a PARP inhibitor like olaparib, this is completely damaged, and this cell cannot recover. The cancer cell, they cannot recover from damage if they have a BRCA mutation plus over and onto it if we use a olaparib. So this is the fundamental mechanism by which a PARP inhibitor like olaparib is used. Now this is usually used in ovarian cancer, but here in breast cancer, you know, BRCA mutation leads to both breast cancer as well as ovarian cancer. So ovarian cancer is we know everything. This is coming to breast cancer, and especially if there is a triple negative breast cancer, then usually the cancer is very fatal, very difficult to treat, chemo-resistant. So in that case, can we improve the overall survival? This is the means crux of the study. Next slide, please. So they did a study, this Olympia study design. So there are two groups. One group they used olaparib, and the another group they used placebo for 1 year. Olaparib dose is 300 milligram twice a day for 1 year. Okay, and what was the group? Adult with, so mostly it has to be HER2 negative. HER2 positive patients are excluded. Second, it is either triple negative breast cancer or estrogen or hormone positive, but HER2 negative patients. They have high risk features like lymph node should be more than 4, more than equal to 4, or residual disease after 6 cycles of neoadjuvant chemotherapy. Okay, so these are mostly aggressive tumors, they will come back. So that's where you intervene with olaparib. And all patients must have a BRCA1 or BRCA2 mutation or both. Okay, and this has been followed up for 10 years. Median follow-up is around 6.5 years, but 10 years from the first day of first case. And primary endpoint is IDFS. IDFS means invasive disease, and DDFS is distant metastasis or overall survival. Okay, and safety features, symptom, health related quality, those things were seen. Next slide, please. So they matched, baseline matching was done. This is a large phase 3 trial, and both arms were having more than 900 patients. They were mostly young. So pre-menopausal was more, like 62%, post-menopausal were 37%. And there are all types of surgery like mastectomy, conservation surgery. BRCA1 was 71%, BRCA2 was 28%. Next slide, please. So this is the result. IDFC was the primary endpoint. IDFC FS for all practical purpose, for all from all faculty members. This is the cancer relapse, and it has to be invasive cancer, not a DCIS. It has to be invasive cancer. It can be anywhere, locally or distant, whatever. First IDFS event should be there. So they said that it is in olaparib group, it is around 19% of patients had relapse, whereas placebo group had 28%. So thereby they get around 10% benefit. And these are the other details, like distant recurrence was 11% versus 16%. CNS recurrence was 2.8% versus 4.4%. Regional, ipsilateral. So these are the all details. And death was also matching. Next slide. So this is the result. 4-year IDFS rate difference was 8.4%, and this is the updated 6-year IDFS rate difference is 9.4%. So there is about 10% of difference when so the drug was used for 1 year and the follow-up is for 10 years. At average 6 year, the IDFS rate difference is 9.4%. So this is statistically significant, and hazard ratio is around 0.65. So this is good. Less than 70, remember, less than 70 is good. And these are the details of events prior. Important, you should note that if there is a prior platinum use, then the hazard ratio is little above 70%, 0.7. So because it says that platinum as well as olaparib both use the same mechanism of DNA damage. So if a patient has already received a platinum prior and the disease has come back, or the disease is trying to come back in spite of olaparib. So olaparib uses this similar mechanism of action of damaging the cancer cell. That's why if prior platinum is used, then the benefit is little less, but though it is there, 0.76. Similarly, if hormone receptor positive or triple negative patients derived more benefit than hormone receptor positive, because hormone receptor positive already is getting benefit of estrogen manipulation, estrogen receptor manipulation. That's why its benefit is less pronounced. Similarly, BRCA1 and BRCA2, there is a difference. BRCA1 are the strongest HRR gene deficiency or homologous recombination point deficiency. That's why BRCA1 deficient patients, their hazard ratio is highest, 0.56. And the final stratified hazard ratio is 0.61. So in this table you can see if the patient has not received platinum, if it is hormone receptor negative or triple negative breast, if it is BRCA1 mutated, then these set of patients, they derive the highest benefit from using 1 year olaparib. Next slide. DDFS means this is distant metastasis. This is again hazard ratio is 0.65, means if you are using this drug, then the metastasis is around 35% less. Here also this stratification, BRCA1, BRCA2, they are different. Platinum, previous use of platinum or hormone receptor positive, these are different. So they derive the highest. You can see here the distant metastasis means if it is platinum previously used, the distant the same means if it is BRCA1, if it is hormone negative, and if it is there is no platinum prior, then they derive the highest benefit. Next slide. Then overall survival. So at 4 years, the overall survival rate difference was 3.2. At 6 years, the overall survival difference is 4.4. Here, the stratified ratio is above 7.7, but it is statistically significant, and the range is 0.56 lowest to 0.93. Next slide. Death in intent to treat population, total death was in olaparib 107 and placebo group 143, and taking the average percentage wise, 11.6% death in olaparib group and 15.6% death in placebo group. Next slide. Safety summary. This is the adversity. So you might be knowing other my other colleagues that olaparib is the important side effect of olaparib is MDS and AML. So myelodysplastic syndrome, it is around 1 to 2% in olaparib group and other groups also. But in this Olympia trial, they try to find out if there is a difference of MDS AML incidence in this group of patients. So, and remember here in ovarian cancer we use 2 years of olaparib. Here we use 1 year of olaparib. So the MDS and AML row, please see at that. The percentage is 0.4% compared to placebo 0.7%. So this is not statistically different. That means MDS AML did not occur with increasing frequency in olaparib group. And similarly, other new primary malignancies, they were also not high in this olaparib group. Next slide. New pregnancy related, there was no difference. Next slide. This is the conclusion. In the third pre-specified interim analysis of the phase 3 Olympia trial, after a median follow-up 6.1 year, 1 year of olaparib after neoadjuvant chemotherapy or adjuvant chemotherapy continued to improve IDFS, DDFS, and OS, overall survival, or relapse or distant metastasis in patients with high risk genomic BRCA1 or 2 mutated, HER2 negated early breast cancer. Remember, we are not talking about metastatic breast cancer. These are all curable early breast cancer patients. We just want to see whether it is relapsing. Benefit of adjuvant olaparib was seen across all groups, including hormone receptor positive diseases. Compared to placebo, the occurrence of new malignancies were lower. There were no new safety signals like MDS or AML did not increase. Investigator conclude that adjuvant olaparib is an effective standard of care in patients with high risk genomic. So this group, and this is currently also advised by NCCN guidelines. Thank you. Answer you can take over.
Thank you so much, Dr. Deva. As we know, lung cancer is seeing major advances in molecular targeting. I now invite Dr. Devrat Hishikar, medical oncologist at NHMMI Hospital, Raipur. Dr. Hishikar will present on optimal treatment in advanced EGFR NSCLC. Over to you, sir.
Hello, good evening, everyone. Can you share my slides, please? Okay. Good evening, everyone. Should I start?
Yes, sir.
Hello. So
Yes, sir. Start.
Okay. Okay. So we'll discuss optimizing treatments in advanced EGFR mutant lung cancers. So we'll find what is EGFR mutation and how it is caused. So EGFR mutation are observed in 40% of Asian and about 20% of non-Asian populations. The incidence rate of EGFR mutation among the Indian patient is approximately 20 to 23%. EGFR mutations are located in the tyrosine kinase domain and result in increased kinase activity of the EGFR. You'll see in the further slides. It leads to continued cell proliferation. So the graph is showing the commonest mutation in the EGFR that are exon 12, 18, 19, 20, and 21. The most common EGFR mutation are deletions in exon 19 and exon 21. L858 are point mutation. So this is the diagram showing how EGFR receptor is and its kinase domain. So the first one is wild type, second is intrinsic mutant EGFR, third is ERBB heterodimer.
Sorry सर, आप नेक्स्ट बोल लिए तब स्लाइड मूव होगा सर.
Okay, sorry. हाँ, next slide please. So next please. So this is the diagram showing the EGFR receptor. The first one is wild type, second is intrinsic mutant. Previous slide. Yes, this one. So the first is wild type of EGFR receptor, second is intrinsic mutant EGFR, third is ERBB heterodimer that is seen in HER2 positive breast cancer, and third is the acquired T790M EGFR mutation. So we'll talk about the TKIs. They are divided into first, second, and third generation. First generation TKIs include erlotinib and gefitinib. They cause reversible binding to the wild type and mutant EGFR receptor. And second, more active in blocking the EGFR receptors. They also block the ERBB family. They have broader activity than first generation. And now the third generation, which is osimertinib, it binds mutate EGFR irreversibly. And it has a specific activity against T790M mutation. It spares the wild type of EGFR receptors. So we'll talk about the next slide. Correct. We'll talk about the FLORA trial, which has made the osimertinib the category 1 indication for metastatic NSCLC. It was a randomized double-blind phase 3 study to assess the safety and efficacy of osimertinib versus the standard of care, which was EGFR TKI as first-line treatment in patients with locally advanced or metastatic EGFR mutant NSCLC. So, how is osimertinib different from first and second generation TKI? Firstly, the structure we will discuss. The first and second generation TKIs are mainly quinazoline backbone, and the third generation, that is osimertinib, has anilino-pyrimidine backbone. First generation mainly binds reversibly to the EGFR receptor, and second and third generation bind irreversibly. And the third generation has mainly action on T790M mutation. One more point for the third generation is it has significant CNS activity. Next slide. So this is the diagram showing how the osimertinib binds with the EGFR T790M mutation and the exon 19 deletion and L858 point mutation. It does not bind or inefficiently bind with the EGFR wild type receptors. It is shown the third diagram. Human and preclinical models. Next slide. So the FLORA study design, patients with locally advanced or metastatic non-small cell lung cancer, the main inclusion criteria were age equal to or greater than 18 years, ECOG performance status of 0 or 1, exon 19 deletion, L858 anti-cancer or EGFR TKI therapy. So divided into two arms. First was osimertinib, second was EGFR TKI, which was standard of care. Osimertinib dose was 80 mg OD, and the standard of care were either gefitinib or erlotinib. Gefitinib dose was 250 mg OD, and erlotinib's dose was 150 mg OD. The response was assessed by RECIST criteria 1.1 every 6 months, 6 weekly until the disease progression. In the second arm, crossover was allowed. That means the patient which progresses on the EGFR TKI will be crossed over to osimertinib. The primary endpoint was the progression-free survival, and the secondary endpoint was overall survival. Other secondary endpoints were duration of response, disease control rate, and depth of response. Next slide. So this is the Kaplan-Meier plot showing a significant improvement in the PFS, which was primary endpoint. The median PFS was 18.9 months versus 10.2 months. Next slide. So this is again the forest plot showing subgroup analysis. All the results are on the left side of line of unity. Next slide. So the FLORA trial showing overall survival. The median overall survival was 38.6 months with osimertinib and 31.8 with the comparator. It may be because there was crossover was allowed, so the overall survival is about the same in both the arms. Osimertinib patients were more likely to be alive at 2 and 3 years landmark. Next slide. So this is the slide showing that 28% of the patients were still receiving osimertinib at the end of 3 years. So which was 3 times more than the patients in the comparator arm, which was 9%. Next slide. So time to first subsequent treatment. In osimertinib arm, it was 25.5 months that the disease progressed on osimertinib and will start chemotherapy. And in comparator arm, either crossover or chemotherapy, it was 13.7 months. So it was just double in osimertinib arm. So efficacy of osimertinib was clearly maintained consistently across all the subgroups, demonstrating its superior benefit across all population, including by race and across the different mutation types. Osimertinib was superior. All OS subgroup shows the positive benefit in favor of osimertinib, but the magnitude was different. Next slide. Next slide. So why osimertinib as the first line? So if we start osimertinib as a first line, then we don't have to test the T790M mutation. If we start a TKI first generation or second generation, after the disease progression, we have T790M mutation before starting osimertinib. So for T790, because T790M mutation develops progressively after the treatments. So we'll see the slides. Approximately 30% of all patients are eligible for osimertinib as second-line treatment of T790M mutation positive NSCLC following progression on first and second generation TKI. Approximately 50% of patients who are alive and who are able to get an accurate test will test T790M positive. Means the patient on whom we have done re-biopsy and tested, 50% of them will T790M positive test. Resistance. 60 to 80% can receive an echo tissue biopsy. Secondly, sometimes false negative results are obtained on the plasma test, that is liquid biopsy, and only about 73-77% of EGFR mutant patients receive any second line therapy. Either they die during the first line or receive only palliative care upon progression. Next. Next slide. So this is the diagram showing if we treat 10 patients, about 80% of the patient will receive second line therapy. In that second line about 60 to 70% will can receive a valid T790M test results, either not eligible for tissue biopsy or have an insufficient tissue or a false negative plasma test. Of that 60 to 70% 790M test that are eligible or any other options. So only about 60 to 80% patients can receive an accurate T790M test result. As I told, the re-biopsy is not possible or plasma testing may yield a false negative result.
Dr. Devrat, I think you can switch off your video because your network is unstable and you have only 2 minutes left.
Okay. So crossover rates and subsequent second line therapies for the FLORA experimental arm. So in osimertinib arm, 22% were still on treatment. 31% patients in the experimental arm could not receive a second line therapy, and 48% received second line therapy, that is chemotherapy or any other line of therapy. So the second arm, the EGFR TKI first generation, 5% patients were still on treatment. 30% of patients in the EGFR TKI arm could not receive any second line therapy, and 65% patients received second line therapy. But 47% of those patients were eligible for second line osimertinib. That corresponds to 31% of patients out of the total. So 1/3 of patients were only eligible to get the osimertinib, which was standard of care. Next slide. Next slide. Next slide. Next slide. In a real-world study of patients with EGFR mutant NSCLC, the risk of not receiving second-line therapy is high. This was retrospectively studied in 140 patients with EGFR mutant NSCLC in Germany. So 130 out of 140 patients were treated with first-line EGFR TKI, out of which 112 patients were candidate for second-line therapy. And out of 112, only 30%, that is 34% patients did not receive second-line therapy. So reasons for not receiving second-line therapy was patient refusal, poor performance status, and fast progression and death. Next. So this is showing the head-to-head clinical trials of EGFR TKI are consistent with the real-world data that not all patients can receive second-line osimertinib, which is the standard of care. So treatment sequencing in advanced EGFR metastatic non-small cell lung cancer, survival with first-line versus second-line osimertinib. So in first-line osimertinib, the it was 18.9 months, followed by disease progression, and patient was all the patients were shifted to chemotherapy. In standard of care arm, it was 10.2 months, and then osimertinib eligible patients were given osimertinib, and chemotherapy was started in osimertinib ineligible patients. So according to this data, only 1/3 of patients were eligible for osimertinib. So the key message is, FLORA trial was the first to demonstrate how an EGFR TKI has translated PFS into an OS benefit. Secondly, osimertinib improved OS versus first generation EGFR TKI in untreated EGFR mutant non-small cell lung cancer and T790M non-small cell lung cancer that has progressed on first line EGFR TKI. Osimertinib is the only EGFR TKI to report statistically significant intracranial efficacy. Osimertinib is well tolerated at its recommended dose of 80 mg. Next is adverse effect leading to dose reductions are frequent in the second generation EGFR TKI, that is afatinib and decomitinib. And sequencing cannot be considered in the best strategy, as almost 70% of the patients are not eligible to receive osimertinib in the second one. So this is the NCCN guidelines showing osimertinib as the preferred treatment, category 1, in EGFR mutation discovered prior to the first line systemic therapy. And if the EGFR mutation is discovered after systemic therapy, then we will consider to complete the systemic therapy and then continue with the osimertinib till disease progression. Thank you.
Thank you so much, Dr. Devrat, for a very detailed presentation. And now we move on to our panel discussion on the role of trastuzumab deruxtecan in HER2-expressing tumors. Moderating the session is Dr. Yashwant Kashyap, Senior Medical Oncologist at Balco Medical Center, Naya Raipur. And joining him are our esteemed panelists, Dr. Bhavna Sirohi, Dr. Nupur Priya, Dr. Rajendra Prasad Patel, Dr. Deba Dulal Biswal, and Dr. Devrat Hishikar. Over to you, Dr. Kashyap.
Thank you, Achal. So as we will be discussing after many sessions, we will be discussing about metastatic breast cancer. I hope my slides are visible and moving. So we are already late, so we'll go slightly fast. So I will discuss about the HER2 testing, which sir has already covered. Then managing brain mets and other thing I will discuss over this. So we have one patient. I will start with a scenario. We have 55-year lady, locally advanced CA breast, given standard TCHP, then surgery, then adjuvant RT and TDM1. Then after 2 years of disease-free survival, she now presented with cough and pain. So on evaluation, she had multiple bone mets and lung mets. So she is ECOG 1. So regarding the rebiopsy, so Deva sir, do you rebiopsy such patient?
Yes, let's rebiopsy him now.
Yes.
Because
Okay.
the cost and implications all are there. So
Yes, yes.
rebiopsy is a very small step. So let's do rebiopsy and IHC.
Okay, sir. So patient underwent repeat biopsy, which was again HER2 positive. So regarding the role of NGS, what do you think, sir?
Yes, NGS, as Dr. Sandeep enumerated detailing that NGS should be done.
Okay, sir.
It
So,
is-
and what if HER2 is lost?
Ah, you're trapping the panel.
Yes.
Hmm.
So,
So,
in,
madam is there. Bhavna madam is there. Let's, Bhavna madam,
So,
please help.
so I think this is what we see sometimes in our clinic also. I would treat as HER2 positive.
Yes, ma'am. Yes. Yes.
thank you, ma'am. Thank you. So now, what options we have? We have trastuzumab, pertuzumab, taxane, then taxane, then TDM1, then any other combinations which we will discuss. So we have already seen in Cleopatra trial that median OS with TCHP is 57 months compared to only 40.8 months with other arm. So now we know that that is standard of care for us. So this patient was started on TCHP. Patient is fine. Also given denosumab for bone mets. Then after around 18 months of all this good control, she again developed the more of lung nodule, then liver nodules. Then what will be the further plan? So Dr. Devrat, what do you think? What will be the your option for such patients? So, Deva sir, what will be your treatment of choice for this patient? After TCHP, patient has progressed. So, what will be your second line therapy?
So initially, yes, one. Initially, you said that he has received TDM1 also. Is it correct, or you
That
want to
was,
correct?
sir, that was in adjuvant setting. That was 3 year back, 3 year, 4 year
Okay.
back.
Okay. So we
Yes.
have again tried with TCHP, and now it
Yes.
has, yeah. So we have, so recently we have discussed such a scenario. We will directly
Yes.
go to TDX.
Yes. So I will show you why Deva sir is saying this, because we have seen in Destiny 03 that in TDXD versus TDM1, this was the trial where primary endpoint was PFS and secondary was OS. So you can see the difference. Though the difference was huge, it was massive. Like in TCH, it was TDXD, PFS was 28.8 months compared to only 6.8 months for TDM1. And we have also seen the Emilia trial where we have used the second line TDM1. There also PFS is only 9.6 months. So we know we are at conclusion that TDM1 has lower PFS compared to TDXD. And regarding the across the subgroup, which I will come later on also, that across PFS benefit was maintained across every patient, like patient with prior pertuzumab, patient with brain mets. So then my next question, so similarly, like many patient had prolonged survival with Destiny 03, which is TDM1 compared to TDXD compared to TDM1. So then I will come to our next question for with for Dr. Rajan. We have very wonderful drug like TDM1, which has shown very good brain penetration. And in earlier slide where I have shown that PFS with TDM1, TDXD in patient with brain met was very good. So do you want to consider patient for SRS or WBRT, or you can avoid it?
So I will prefer, sir, SRS in this case because the size is small and there is no other, not a multiple brain mets, single lesion. It is good for SRS.
Okay. So, Dr. Nupur, do you, if consider other case, if patient had oligomet disease, so do you would have advice also for breast surgery, or you would have considered patient metastatic only, HER2 positive patient?
First, we'll see whether the site of metastasis is. If it is single bone only lesion, then yes, we can consider. But if it is liver lesion or lung, then it is better to continue on palliative chemotherapy for the patient.
Okay, so HER2 you are not comfortable for oligomet. Okay, so like the Dr. Rajan was saying that we have option. This slide shows that patient with multiple brain mets, we can go for WBRT followed by systemic therapy. If patient is asymptomatic, then we have now many potent drug which I will discuss. We can offer for our patient, and for oligomet metastatic disease, which is more defined for hormone positive. But even in HER2, because we have now many wonderful drugs like TDM1, TDXD, tucatinib. So such patient can case to case basis after discussion in MDT can also be offered MD surgery also for primary also and for breast also. So this was the trial where tucatinib and TDXD was compared. So here brain penetration was slightly better with tucatinib, but still TDXD overall response rate was more. Regarding the patient brain response also, that TDXD had better response. So this patient was started on TDXD, which is trastuzumab deruxtecan with 5.4 mg per kg every 3 weekly for this patient. Here you can see that the response rate which and safety compared to TD1 all was comparable in both the group, and ILD, which is dreaded complication which we always worried with TDXD, was also lesser. And main side effect was vomiting, which that's why we recommend three or four drug regime to prevent MSS. So then what after Deva sir, what are your experience with TDXD?
I have no experience with TDXD. My patients could not have till now not affording for TDXD.
Okay, sir. But
I have heard from my dear colleagues in Raipur
yes,
that
sir.
it's a wonderful drug.
Yes,
and Madam has also said it's a working wonderfully. So we are
yes,
all.
sir. So yes, sir. Sir, you will give it in second line or third line or fourth line?
Second
line. Yes, sir. So
Coming
similarly, we have a patient recently now. Patient had prolonged disease-free interval with pertuzumab for around 18 months, 20 months. Due to financial issues, though we have started him on her on TDM1, but still TDXD is a good option for her looking at all this data. So this is the final chart which I wanted to show. We are very much convinced with Texan, Trastu and Pertu. For second line, we have option of TDXD plus with radiation, as Dr. Rajan told. For patient with active CNS disease, we can offer tucatinib also, but tucatinib need to be imported. Then third line, we have option of TDM1 and other options. So with this, I conclude. Thank you, panelists.
recently TDXD is offering patient assistance program also.
Yes, sir. Yes, sir. And yes, sir. So hopefully in future cost will be more feasible for our patient, and we can offer this wonderful drug in second line setting also. So thank you, sir. Over to you, Achal. Thank you.
Thank you so much, Dr. Yashwant and our esteemed panelist. With this, we come to the end of today's discussion. A sincere thanks to all our speakers, panelists, and our participants for joining in today's session. A special thanks to our chairpersons, Dr. Bhavna Sirohi, Dr. Gaurav Gupta, and Dr. Nupur Priya. I would also like to mention our industry partners, AstraZeneca, Intas, MCure, and OneCell, for making such academic discussions possible. I would like to invite you all to our future BMC Oncology webinar series hosted by Balco Medical Center, Naya Raipur. Thank you, everyone. Have a great evening.